Hi there, everybody. Good afternoon and welcome to our third webinar in the series on achieving accuracy in medical journalism. To stem the flow of false information, journalists have a vital role to play in ensuring that the public receives accurate medical and health information. So on that basis, we decided to develop this webinar series to boost the skills of journalists and journalism scholars. In the first webinar, we provided an overview on the key issues, and I've provided a link to that webinar in the chat box if you want to check it out. It's on YouTube. The second series was on healthcare for trans people. That webinar will unfortunately not be made public, but please contact me on the email that I put in the chat box if you would like more information about it. As you may know, the World Health Organization has flagged false vaccine information as a key public health issue in the world today, with anti-vaccine messages being shared and boosted by some very high-profile individuals. My own research shows that false information about vaccines circulating in South Africa is similar to that circulating globally, mostly driven by conspiracy theories, inflated statistics on vaccine injuries, and concerns about the safety of what's in the vaccines. Firstly, it is important to understand that false information about vaccines leads to vaccine hesitancy and vaccine refusal, which can lead to the spread of disease and in some cases unnecessary death. Unfortunately, Dr. Duduzile Ndwandwe-Mashini was unwell today, so she couldn't attend and give us her talk. However, Prof. Michelle Groom has kindly agreed to step in at the last minute to tell us more about the impact of vaccine hesitancy and vaccine refusal in South Africa. Prof. Groom is a medical doctor and infectious disease epidemiologist. Her main areas of interest include enteric and respiratory diseases and vaccines to protect against the causative pathogens. She has more than 20 years' experience in the field of infectious disease and vaccinology, including conduct of clinical vaccine trials, respiratory and diarrheal disease surveillance programs, and observational studies assessing vaccine impact, effectiveness, immunogenicity, and safety in South Africa. She is currently a principal researcher at the University of Witwatersrand Vaccines and Infectious Diseases Analytical Research Unit, where she leads the adult surveillance portfolio and the maternal immunization ready network in Africa and Asia. During the COVID-19 pandemic, she was the head of the Division of Public Health Surveillance and Response at the National Institute for Communicable Diseases and played a pivotal role in our pandemic response. Michelle, could you kindly go ahead and give us your insights onto what the impact is of not vaccinating?
Great, and thanks so much for the opportunity, and apologies I don't have any slides. I think this was rather last minute, didn't really have a chance to provide a slide deck for you, so I'll just be speaking to the topic and hopefully we'll be able to do justice to the talk, and happy to take any questions if you have anything specific. I think there's a Q&A at the end. So I think really just to start off with saying that vaccines have really been one of the most important and the most effective interventions that have been introduced. And the use of vaccines is really, has been shown over the last decade or more through preventing severe disease of infectious diseases. And so how vaccines work, I'm sure you're familiar. So we will inject, vaccines can either be oral or injectable. So in case of an injectable vaccine, we would inject the vaccine. There are many different types of vaccines. They work in slightly different ways. But what we really want to do is to try and mimic the natural infection. And so we would actually then give a kind of part of the virus or the bacteria into your body. It doesn't cause the disease itself, but the body recognizes it as being foreign and produces antibodies. and those remain in your body. And then the next time when you see the actual disease, your body already has these antibodies or the memory of these antibodies and some circulating antibodies, which will then increase in number and fight off the pathogen. And so we can either protect individuals, so we can get vaccines ourselves. We all receive vaccines, hopefully, as infants. There are some adult vaccines. Another way to protect individuals is actually by, for example, vaccinating a pregnant woman, and she generates antibodies in her body, which are then passed on to her baby through the placenta and through breast milk, and can actually give protection to the baby through the first 6 months of life. And so vaccines obviously reduce disease in individuals. And there was a recent publication in The Lancet, which I'm happy to share with you as well, just showing the impact of vaccines over the past 50 years. And so there's been this tremendous impact, particularly in infant mortality. So that's deaths in children under 1 year of age. And so there's been a 40 to 50% reduction. So 40% in kind of your more high income countries, and just over 50% in countries on the African continent. And so what this kind of means is that when they did the study, they did some modeling around the impact of vaccines and showed that in 2024, children under 10 years old had a 40% better chance of living to their next birthday compared to if there had been no vaccines available. And so we know that at the turn of the century, many years ago, and probably from your mothers, maybe, or grandmothers, really remember these diseases and the severe mortality in families. I mean, where most families had at least a death of one, if not more, children due to infectious diseases. And so this increased chance of actually living to your next birthday is really a significant impact. And that extends through your whole life. So even as adults, if we were vaccinated as children, we have this increased protection against infectious diseases. And so really diseases that were very common kind of 50 years ago, we hardly see them anymore. And so even as a doctor, when I was doing my internship and working in the public sector, diseases like measles and diphtheria were really uncommon because these vaccines have been in use for a number of years, and we really don't see a lot of that disease anymore. More recently, there's been vaccines that have introduced for meningitis. And so I remember also during my internship, one of the causes of meningitis is a bacteria called Haemophilus. And so it really causes, severe disease and death in young children, but also has a lot of long-term effects. And so a baby who gets meningitis, there's that illness at that time, but many of them are left deaf or blind, may not be able to walk properly. So there's a lot of damage that gets done through that initial infection, which is kind of very long-lasting. And so in 1999, there was a vaccine introduced against Haemophilus, and now it's very rare to see babies born with this type of meningitis. Also, just to give the example of the rotavirus vaccine. So rotavirus is the most common cause of diarrhea in young children. And prior to that vaccine being introduced, for example, at Barrow, we had a whole ward that was dedicated to infections due to diarrhea. And so rotavirus has a clear season. It's usually during the autumn and winter months. And so we used to have this ward full of babies coming in who were severely dehydrated, needing to get fluids. And once the vaccine was introduced, that ward was actually decommissioned at Barrow and has been used, for other conditions now, just because of the impact that the rotavirus vaccine had in terms of decreasing disease due to acute diarrheal disease. And so that's, there's the benefits in terms of reducing individual disease in the person, but there's also this impact on the health system, where by preventing disease, the health systems have more capacity to deal with other infections that we don't yet have vaccines for, or for chronic conditions. And so really does alleviate some of that burden. So I think one of the difficulties at the moment is vaccines have done an excellent job of preventing all these diseases. And in a way, people, and many in the younger generation, have actually forgotten what these diseases were or can do. And so it makes it a bit more difficult to try and have people understand what these diseases and their consequences were. For example, measles, I've definitely heard it either in the media or people say, but, I'd rather just have natural infection, than generate a good antibody response by getting, the natural infection rather than the vaccine. Forgetting that, in days gone by when measles was very common, that many babies died. I think measles, it's not just the rash that comes, it affects your whole body, and so can affect the brain with inflammation of that lining around the brain, which can take place many years later. So it could, if you have it as a young child, you may have these manifestations much later in say teenage life. And things like, polio, I think at one stage, there were many people who suffered death or deformity from polio. And so we don't see those diseases. And I think people forget that having the natural disease, comes with a lot of these consequences. And so it's kind of trying to remind people that these diseases are not commonplace because of the impact that vaccines have actually had. So if we really just think around what might happen if we don't have vaccines, I think is that, or if the vaccine coverage starts decreasing, we'll really start seeing resurgence in many of these diseases that have almost been eradicated. So if we take a disease like polio, we haven't had a polio case for many, many years in South Africa. There are areas of the world which still are having polio. But in many countries, this has been eradicated. And so if the rates of vaccination start going down, we really will start seeing these diseases coming back. And I think it will come back slowly. I think diseases like measles are spread very, very easily between people. And so we need very high kind of coverage of the vaccine. More than 90% of the population needs to be vaccinated to prevent the spread of measles. And so measles is probably the first one that you will start seeing occurring as outbreaks. And we have, after COVID, had a recent measles outbreak in South Africa. I think in the US at the moment, they're having the largest measles outbreak, I think, in decades. And so we really will start slowly seeing resurgences of these diseases. I think another one in South Africa where we've seen increased cases is in diphtheria. So diphtheria is a disease many do not even know about. It starts as a sore throat, like many other viruses that are circulating. This is a bacteria, and it actually inflames the throat and the nasal passages and can cause this thick kind of membrane, which can actually obstruct breathing. It can also cause damage to the heart and kidneys, and has a very high mortality rate. And so we have been seeing increases in diphtheria as well, which was really a disease, again, that we didn't really see much of. And so slowly, if our vaccine coverage continues to decrease in this way, we'll slowly start seeing resurgence of these diseases that we really have brought under control. I think also important to note with vaccines is that although it's an individual choice to have a vaccine, the protection that you give is not only for the individual. So if I decide to vaccinate myself, my children, I'm protecting myself against diseases, but I'm also protecting those around me. So there are some children who are not able to have vaccines. Maybe they have a disorder with their immune system and are unable to be vaccinated. And so those that are vaccinated can actually protect those around them. And so what we see, especially if there's pockets of the population where there may be increased, hesitancy to take vaccines, you'll find that more and more people are unvaccinated. And therefore you get these pockets of what we call susceptible people. So those are people who are actually susceptible to the disease. And that's often where your outbreaks will start. And so although it's my choice to vaccinate or not vaccinate, it really does have an important impact in terms of overall circulation of the disease, and protecting those that are vulnerable. So we've really seen, even with many of the childhood vaccines, they can even protect the elderly. So often in the elderly, it's the grandchildren that are transmitting infection through to their grandparents. And so if you're protecting the children against the infection and they're not getting sick, we've also seen these reductions then in disease in the elderly, because we interrupting that transmission of disease. And so vaccines, as I said, is an individual level, but it's also decreasing the overall burden of disease kind of in the population. And so we've also, I think if you'll remember back, I'm sure most of us remember back to the COVID pandemic. And I think that's just an example where, that was a new disease that had come in, but we saw our health systems really being overwhelmed. I think if you remember back to that Delta wave with many of the hospitals full, not being able to take other, patients, any more patients. And I think once again, with resurgence of diseases with decreased vaccination, if you've seen this, increase in diseases that we're not seeing a lot of at the moment, it's really going to impact the health system and start overwhelming our health system. How many?
3.
Okay. Overwhelming our health systems in terms of, now being, if the wards become full of children with diarrhea again or with measles or diphtheria, it really means that we're not able to dedicate those very important resources to other health conditions. And I think we do, I think post-COVID, we're in a different kind of, paradigm in a way. I think our EPR system and the childhood vaccination system, has really been, most people are quite accepting of the vaccines that are given to children. And I've never really questioned it. And I think we've always had high coverage rates in terms of our EPR vaccines. But somehow with the shift during COVID, where, these were now vaccines that we're giving in the adults started to kind of have some questions, and with a lot of the misinformation that was circulating around that time, it really did impact then choices they were making for their children. And so I think we really are kind of in this era where there's a lot more questions around vaccines. And I think the other speakers will deal with kind of the safety issues around vaccines. And I think, information is just so accessible these days, and the wrong information gets out there really quickly. And I think even for me, I think some of the newer platforms, I'm not even familiar with, but for the younger generations, TikTok and these are ways to get information out quickly, whereas maybe the researchers are still in an era where, we would think people would find that information in a different way. And so just the way we think about information and the sources of this information, which I think will also be dealt with in this webinar, I think are really important. And there's this greater access to information, but a lot of it is by people who do not understand, don't quite know how to read, a scientific paper. Someone will take some information out of that, misinterpret it, and put it forward as fact. Healthcare workers we saw during COVID are really important in terms of promoting faith in vaccines. And so if you have healthcare workers which are speaking out against vaccination, I think really also important in terms of trying to understand where even the information from healthcare professionals are coming. Because I think we saw in COVID, it was, not even someone who was familiar with the topic, wasn't really a vaccinologist who was speaking to that. So I guess really just to end off, I think it's really, the tremendous impact of vaccines that we have seen. And as I say, I can share some kind of publications that would really be able to help you in terms of framing this, in terms of maybe the way you start off articles around vaccination, or if you're dealing with any questions that you may have. Really just to frame this in terms of this tremendous impact that vaccines have had, just in terms of decreasing, especially mortality in children. And I think really, I'm sure amongst all of us who have kids, I think very few of our children are dying, where 50 to 100 years ago, we would have been losing many of our kids due to these diseases. So I think I'll stop there, and I'm happy
Great.
to
Thank
take
you
any
so much.
additional questions later.
Thank you so much, Prof. Broom. So thank you for highlighting for us the important impact that having vaccinations has and the detriment to the public health system that comes from not being vaccinated. It's clear that good vaccine coverage is vital to public health in South Africa, if not globally. But in order for us to understand the issue better, let's explore a bit more who is driving the spread of false vaccine information. As I stated in the intro, my own research highlights that false information being spread in South Africa is very similar to the information being spread globally. So we know it's not just a South African problem. Dr. Mallory Harris will give us some idea of who is generating these global flows of false information about vaccines. Dr. Harris is a postdoctoral associate in the Department of Biology and at the Institute for Health Computing at the University of Maryland. She obtained her PhD in biology from Stanford University and was a visiting graduate at the Center for Informed Public at the University of Washington. At Stanford, she was the president of Scientists Speak Up, an organization focused on communicating science and countering scientific misinformation. She uses quantitative methods to study the interplay between human behavior and infectious diseases. Dr. Harris will be giving us more insight into the global circuits of false vaccine information. Dr. Harris, please go ahead with your presentation.
All right. Does everything look good? Y'all can hear me?
Yes, great. Thank you so much. Go ahead.
Okay, excellent. So I am going to be focusing here on a specific group that has been really important in the spread of information about vaccines kind of on both sides. So starting off, and we heard some about this in the prior presentation, healthcare providers and other experts, people like scientists, actually remain trusted sources of vaccine information who are generally some of the most effective messengers who are able to convince people to get vaccinated. However, there hasn't been as much work looking at this from the opposite direction, namely, what happens if there's someone who looks like an expert, maybe they have doctor or PhD next to their name, but they're actually telling you not to get vaccinated and maybe spreading false claims about a vaccine. Now, anecdotally, and I have a few examples here, some of the highest profile sources of vaccine misinformation have been people who have credentials. Some of them have been licensed medical professionals, and this has been observed anecdotally, but it hasn't been studied systematically to really try to understand how many of these perceived experts are there within the anti-vaccine community, and how important are they actually in the vaccine conversation. So just a quick note on terminology. I'm going to be using the phrase perceived experts here to emphasize that we're really focused on things from the perspective of an audience on social media, where you often have really limited information about your sources, usually just a little bit of biographical information on their profile. You're not necessarily validating those credentials, you're kind of taking people at their word. And we have validated experimentally that certain cues, things like doctor, MD, physician, lead people to be viewed as more expert on vaccines, kind of regardless of whether the audience, what their vaccine attitude is and what their political partisanship is. So this is what I mean when I say perceived experts. You have some signal of expertise in your profile, but importantly, those cues might be misunderstood by the audience or misrepresented, and we didn't actually validate them. Okay, so our two key questions here. First, we just want to sort of describe this group of perceived experts in the anti-vaccine community. How many of them are there? what kind of things are they talking about. And then second, we want to actually try to examine their influence relative to people who aren't perceived experts. So do you actually get some sort of boost from being a perceived expert within the anti-vaccine community? And to do this study, we used Twitter data that was retrieved and stored in real time. We focused on April of 2021, which is when all adults in the US became eligible for vaccination. And we were retrieving tweets globally. We didn't have a geographic restriction, but our keywords were limited to English language keywords about COVID vaccines. And so when we did this filtering, we wound up with 4.2 million tweets and 5.5 million users who participated in the conversation, either by posting their own original content or retweeting, which is when you share someone else's post. So from that large group of tweets, we kind of want to focus in on what we'll call micro-influencers, people who are getting some amount of engagement with their tweets. And we're going to construct what's called a co-engagement network. And here, 2 users will be connected if they've both been retweeted at least 10 times by at least 2 of the same users. So that means if they're connected, they have some sort of shared audience engaging with their posts. And you only show up in the co-engagement network if you are connected to someone else. So you have to be getting some amount of engagement with your tweets. You can think of this as meaning that our network is focused on this group of micro-influencers, people who are getting some amount of attention on the things that they're posting. So we wind up with about a little under 8,000 users. They're the circles. I'll get back to the size of those circles, but the lines are the connections between them. And you can see here already that there's some clustering within the network of sort of groups that are all interconnected with each other. And indeed, when we apply a community detection algorithm, this network breaks into 2 large communities based on its structure. And then we took a sample of popular tweets in both communities to determine that the larger community with just under 3,500 users was generally pro-vaccine, arguing that vaccines are safe and effective. And then this pink group that's slightly smaller was generally anti-vaccine. And I'm happy to take questions about these sort of subclusters that we see, because there's some interesting dynamics there. Okay, so now we have the communities. Where are our perceived experts? Now, to figure that out, we had to look at all of the profiles of the users in the co-engagement network. So I worked with 2 research assistants here. And again, we were looking for those credentials in the bio that indicate biomedical expertise. And so here I'm showing you the kind of hue indicates what type of user you are. So the lighter colors, you can see some over here. And over here, those are accounts that we excluded either because they were not individuals, so things like a government agency or a radio station. We really want to focus on comparing individuals to individuals, or their profile wasn't in English, which made it hard for us to evaluate whether they were perceived experts. And also, since we have English language keywords, there's some biases in what we would be sampling there. So we're going to exclude those users. The medium colors are perceived non-experts, so you don't have those cues in your profile. And then the darker colors are perceived experts. So you can see they're showing up in both communities. They're about a fifth of the pro-vaccine community individuals, but they also have a pretty sizable presence in the anti-vaccine community. So they're about 10% of those individual accounts, and there are 185 of them. So it's not just those 4 examples that I showed at the beginning. Okay, so now we know that they are out there. The next question is we want to get a taste of sort of what they're talking about. And in order to understand that, we're looking at the sources that they share. So here's an example of a tweet with a link. I'm going to explain my methods here. So we're going to focus in on the domain name. In this case, it would be potionstudies.com. And we'll compare that domain name to a list of low quality sources. These are sources that have repeatedly failed fact checks, as determined by the fact checking organization Media Bias Fact Check. And this is a common approach used in sort of studying information flow, that if you are sharing these low quality sources, you might be sharing misinformation. It's sort of a proxy for that. So here I'm breaking things down by the user type. So we have our perceived experts on the left, perceived non-experts on the right. Pink is anti-vaccine community, green is pro-vaccine community. And our y-axis is the proportion of users in a given group who shared at least one low-quality source. So you can see here that those low-quality sources are almost entirely coming from the anti-vaccine community. So they are potential sources of misinformation. Also, I'll note there's actually no real difference between the proportion of users who shared those low quality sources if we compared perceived experts and perceived non-experts in the anti-vaccine community. So this is suggesting that those perceived experts in the anti-vaccine community are also sharing those low quality sources, potential misinformation. The second thing that we looked at are scientific sources. So these are either peer-reviewed journals or preprints. And here the big difference is between perceived experts and perceived non-experts, where in both community, perceived experts were more likely to share an academic source. And again, that sharing of academic sources is kind of level between the anti-vaccine and pro-vaccine community. Although I'll add a really important caveat, which is that we didn't look at all at what sources were you sharing. There's some journals, there's some articles that are more reliable than others, and we didn't look at how they were interpreting those academic sources. But I'm happy to answer questions about that. There's been some other work that looks at scientific link sharing in the anti-vaccine community. Okay, so now we have a bit of a clearer sense of who these people are, what they might be talking about. The next question is like, do they matter? So you might assume that if you're anti-vaccine, you don't care what experts have to say. But or you might say that, you know, in both communities, they really care about perceived experts. So the first thing that we looked at here is centrality, degree centrality. That's how many other users you're connected to. It's correlated with the size of your audience. And that's corresponding to the size of those users. So those big circles are very central, which indicates that you might be playing an important role in information flow. Now, it does jump out that there are a few perceived experts in both communities that are pretty large, but we actually tested this statistically and found that perceived experts were overrepresented in the group of the most central users by a factor of 2. So they're disproportionately showing up in these key roles for information sharing. And one other sort of interesting thing from a network perspective are these users who show up between the two communities. I'll call them bridges. And that means you're getting engagement from both the anti and pro, or people who engage with both the anti-vaccine and the pro-vaccine community. So you play this sort of intermediate role. And we found that about half of the most important bridges, so out of the 10 users that bridge the communities the most, 5 of them are perceived experts. And again, they're only there at about 17% of the population. So they're way overrepresented as these key bridges between the two communities. And then lastly, we want to ask, are they getting more engagements with their posts? So on Twitter, you can like or retweet another post to kind of show that you are responding positively. And we want to ask whether perceived experts on average get more engagements than similar perceived non-experts. So to test this out, we do what's called propensity score matching. That means that for each perceived expert, we're going to look for perceived non-expert who is similar with respect to various profile characteristics. They tweet about the same amount of times they joined around the same time, they have similar numbers of followers. Those are all things that could affect the amount of engagements that you get, and we want to control for those to isolate the effects of being a perceived expert. So we're asking, like, for example, how much does adding doctor to your profile increase the number of engagements that you would get? So I'm going to build up a more complicated figure here. The x-axis here is going to be the average difference between our group of perceived experts and perceived non-experts with respect to a different influence metric. So that's the size of the boost that you get from being a perceived expert. If it is positive to the right of this dashed line, then we're saying that perceived experts get more engagements. And then the y-axis, we're going to look at just different ways of measuring influence based on likes and retweets. So to start out with just one number, if we compare the median retweets that you get across your posts, and we just look in the anti-vaccine community, perceived experts do get a significant influence boost. They're about 1.43 times more likely to get retweets on their median post. And we can look at other ways of measuring influence. And we found that for 3 out of 4 of these influence metrics, perceived experts were outperforming perceived non-experts within the anti-vaccine community. So this is telling us that within the anti-vaccine community, perceived experts are in fact getting more engagements. And the last thing I'm going to show you before I close out is the size of these boosts for the pro-vaccine community. And I want you to just take 1 second, like form a mental hypothesis. Do you think that you get more of a boost from being a perceived expert if you're in the anti-vaccine community or the pro-vaccine community? This is like a nice time to just check what are your preconceptions about this. So I'll let you lock in your expectation. But what we found is actually that there was no significant difference in the size of that influence boost between the two communities. So also in the pro-vaccine community, you get a boost from being a perceived expert, and it's on par with what you get in the anti-vaccine community. Okay, so I'm going to close out and kind of in more plain English give you a sense of what we found and why I think it's important. So first, we were able to go beyond prior work that points to a handful of perceived experts in the anti-vaccine community and really establish that they're a sizable group. We found close to 200 of them, which suggests that this is more of a systematic problem than a problem of a couple of people. And we found that they were using this sort of interesting mix of sources where they're sharing both potential misinformation and academic sources. So if we're talking about how to address misinformation from these sources, we need to consider that sort of unique communication style. And then secondly, we were able to show that perceived experts are actually relatively more influential than similar perceived non-experts. They were disproportionately central within the network, and they get more engagement than other individuals. And we found that the size of that influence boost was similar between both the anti and pro-vaccine communities, which contradicts the expectation that some people have, again, that the anti-vaccine community simply doesn't care what experts have to say. Rather, we found that within the anti-vaccine community, people are highly engaged with their own set of perceived experts. So in sum, perceived experts are not only some of the most effective sources countering anti-vaccine misinformation, they may also be some of its most important sources. So with that, I'd like to acknowledge my funding sources and my collaborators. This project is actually published in PNAS Nexus. You can contact me on these things in the top left, and I'm looking forward to your questions.
Thanks so much, Dr. Harris, for that input. I mean, the research very clearly shows the importance of checking the credentials of perceived experts for journalists because they have an oversized influence but may not actually be authorities on the subject. Therefore, as we highlighted in our previous webinar, on how to check out the true expertise, we need to emphasize that not that just because someone has a doctor on their name does not mean that they, for example, are a vaccine expert. Again, the link to the first webinar is in the chat box. So if you want to look into more about how to identify whether someone has expertise or not, please check out that video. Okay, so apart from conspiracies theories, some of the key false information being spread about vaccine is in relation to vaccine safety, particularly the number of incidents of vaccine injury and also the composition of vaccines. Therefore, it's really important to understand the safety issues around vaccines. And Prof. Hanani Meyer will be giving us some reassuring insights into what protocols are in place on vaccines safety and what the compositions of vaccines is. Prof. Hanani is the head of the South African Vaccine and Immunization Center at the Sefako Health Sciences University. She serves on the World Health Organization Global Advisory Committee on Vaccine Safety and chairs the African Union Smart Safety Surveillance Interim Joint Signal Management Group, facilitating cross-country signal management for health products in Africa. She is also a public health pharmacist who has served on the South African pharmaceutical and public health sectors for 40 years. The Minister of Health appointed her to the National Immunization Safety Expert Committee, which she chairs, the National Advisory Group on Immunization, and the Board of South African Health Products Regulatory Authority. She specializes in vaccine safety, vaccine hesitancy, and vaccination as a pillar of antimicrobial stewardship. She is a National Research Foundation-rated scientist, and her research aims to strengthen healthcare services, improve public health, and contribute to achieving our Sustainable Development Goal for health and well-being. Dr. Hanani, if you please go ahead with your presentation. And you have 15 minutes.
Can you see my screen?
Yes, we can see it. Thank you very much.
Okay, and you see the full version? No, the full version of my slides.
Yes, thank you very much.
Okay, good. Sorry, I didn't have my mic on, but thank you so much for the introduction, and thank you for the opportunity to present here today. So I'm going to, as you explained, I'm going to focus more on the medical evidence regarding vaccines. And here are just my disclosures, potential conflicts of interest, but my real conflict of interest, I always tell people, is the fact that I'm very, very passionate about vaccination. So although the next speaker will now focus on more like how to refute these common myths around vaccination, as I said, I'm going to focus on the scientific, information and facts about vaccines. So let me start. Michelle also mentioned it. I mean, we all know how successful vaccines are and that they save so many lives. So basically, as you can see here, every day for the past 5 decades, 6 lives are being saved per minute, due to the success of vaccines. But like Michelle also alluded to, and the previous speaker, we see a lot of misinformation and disinformation. And here in South Africa, we are all aware of the fact that there are vaccine-preventable disease outbreaks, and we see low uptake of vaccines. So when you go, for example, I just went to the Facebook page of the Department of Health, And you can see these scams and you know, almost like campaigns of misinformation, where they even used, you know, the very well-known Professor Salim Karim, where they actually used his image to spread fake news. And then when you look at the comments, you know, when, you know, for example, the Department of Health would warn people against this, then you will see all these negative comments also coming through. And this is not only the case in South Africa, so globally, like Michelle mentioned, and as we've seen in the previous presentation, globally it's a problem with the spread of misinformation. And it creates a lot of anxiety and mistrust in the vaccines as well as the health authorities. So we're all very much aware of RFK in Robert F. Kennedy in the US. And, you know, the fact that he is strongly believing and, you know, spreading a lot of misinformation and creating a lot of anxiety around the question whether vaccines is actually responsible for autism in children. And as you can see here from the Pediatric Association, they actually put out a statement to say that, you know, there's so much confusion amongst parents, and what's supposed to be, you know, just a well baby or a healthy child, well child visit is now really a big problem because they need to deal with all this anxiety around vaccination. So where is all of this coming from? So during COVID-19, they did this study on following people on social media, where they actually followed 59 million people on social media, and they identified 12 people, which they then labeled the disinformation dozen, being responsible for up to 65% of the anti-vaccine content being spread on social media. Some people, as you can see here, also refer to them as the dirty dozen. And they put the names out there of the 12 people. And as you can see there, number 2 is Robert F. Kennedy, which is really a great concern. And we can see now the influence it has, you know, globally, based on what he is saying and the way he is managing health in the US. So, you know, where did all of this start around autism and specifically the measles vaccine? So way back in 1998, Andrew Wakefield published this paper in the Lancet, suggesting that the MMR vaccine causes autism in children. However, he only studied 12 children, all of whom had autism, and his study was found to be fraudulent. He made some false claims. He had no scientific basis for his claims. And eventually the Lancet retracted the article, but it took 12 years for this to happen. And at the same time, he was also removed from the General Medical Council in Britain. But still today, people are referring to what he published in the Lancet. So despite the fact that there are now so many scientific articles out there saying and showing that there is no link between the measles vaccine and the development of autism in children, as you can see here, so you can actually go out and look for those articles. There are many of them. And there's also one article where they were quantifying the effect of this on skepticism around the MMR vaccine. And they also made the statement that, you know, the skepticism increased following this publication. And it was potentially being made possible by negative media and negative coverage about the MMR vaccine. So what are people's main concerns when it comes to vaccines and vaccination? So I'm just going to give you 2 examples. So the first one is the study was conducted across Africa, and they looked at, you know, confidence in the importance of vaccines for children. And as you can see here, the 3 main issues was whether it's important for children, are these vaccines safe, and are they really effective? So if you look at the colors on this image, so the purple or the blue colors, denote a decrease in confidence, and pink is an increase in confidence. And as you can see, we are mostly observing the blue and the purple colors. Then after COVID-19, we also did a study in South Africa, amongst 400 people. And again, we found that about a third of people still believe that vaccines can cause conditions such as autism and infertility, that they contain dangerous ingredients, that health professionals are giving children too many vaccines. They have long-term side effects, and the majority of people didn't have trust in vaccines that haven't been on the market for a long period of time. So why do people actually have these concerns about vaccination? And Michelle actually also spoke about it, but we refer to this as the Pyrrhic victory of vaccination, which means that because vaccines are so successful, they prevent these diseases and you don't see them anymore. So now people would pay attention to the side effects or the adverse effects that's now visible because you don't see the diseases anymore. And if these concerns are not being addressed, then acceptance and confidence in vaccines will decrease. So in the end, people's perceptions get completely distorted around the risk and the safety of vaccines, because the vaccine preventable disease is now hidden, and what they are seeing is just the side effects, even if it's just a few people, but that's the only event that they can now see. So it's important to understand that when people make a decision around vaccination, they assess the risk based on the probability, how likely is it going to happen, and also then if it should happen, the severity, how serious will it be. So if people have a high level of risk they perceive a high level of risk related to the vaccine, they will not get vaccinated and they will not get their child vaccinated. On the other hand, if they perceive a high level of risk, should they get the disease or the child would get the disease, then they will get the child vaccinated or themselves vaccinated. So what is important is also to understand that the perception of risk is different when you look at scientists and when you look at the public. So scientists would base their perceptions of risk on scientific evidence, while on the other hand, the public will base their risk and being influenced by emotions, engagement with other people, and in the face of fear, anger, outrage, and especially where there's poor health literacy, there is really a poor benefit risk understanding amongst the public. So we need to understand this, especially when we start writing about these things and about the safety of vaccines. But are these vaccines now really safe? So do we have actually the scientific evidence for that? So if we look at vaccines, they go through clinical trials. So the first phase of a clinical trial is small, as you can see, 20 to 100 volunteers. And, they look at the safety, are there any serious side effects, and what is the immune response? Does it work? Then when it's successful, they move to the second phase of the clinical trial, where that's now being conducted among several hundreds of healthy volunteers. And again, looking at the safety, the short-term side effects, immunogenicity, and also the dose response of the vaccine in the person. And then phase 3 is now hundreds of thousands of healthy volunteers. And again, they look at the safety and the efficacy of the vaccine. So these clinical trials take place amongst adults, healthy adults, and no vaccine will ever be registered unless it has passed through all 3 stages of clinical trials. So there were lots of questions, especially during COVID-19, about the duration with which these vaccines came on the market. So as I've explained in the previous slide, you can see here at the top, this is how the vaccines will then move through the different phases of the clinical trials, and at the same time, the manufacturing of the vaccine is scaled up depending on the size of the trial or the phase of the trial. But during the pandemic, none of these phases were skipped. What happened is some of these things happened at the same time. Some of these phases actually overlapped. And we also need to bear in mind that there were many people volunteering to participate in the trial. So it was much easier for them to do the recruitment, and there were also lots of funding made available for the vaccines. And the vaccine manufacturers actually put themselves out there by manufacturing these vaccines to be ready when, the findings were reviewed and the vaccine was found to be efficacious and safe to be registered. So that's some of the reasons which people do not understand. Now, a vaccine will never be registered on the market unless the regulatory authority has found it to be safe. It has a good efficacy, high efficacy, and of good quality. And they would always weigh the risk of a rare adverse event against the risk of a vaccine-preventable disease. So it must be able to protect against a vaccine-preventable disease. Only after that, in South Africa, each and every batch of a vaccine is then tested by the National Control Laboratory in Bloemfontein. So no vaccine will, whether it's coming, from outside South Africa or from inside South Africa, it will not go onto the market unless it has gone through the testing at the National Control Laboratory to make sure that these vaccines are really safe. Then it is administered to the larger population. And now there are people from different age groups, they've got underlying conditions. And, so it's not the same population, which is very controlled in a clinical trial. So what we see in the clinical trials is the very, very common side effects or adverse effects in the case of vaccines. And they are, they usually are not very serious. They are very short-lived. They clear up within a couple of days on their own. They're mild and moderate, and normally you would not need any treatment. But clinical trials can never be powered large enough to be able to detect very, very rare adverse events. And that is the reason why we need post-marketing surveillance, where vaccines are being followed up after it's been registered and it's out on the market. And there we also see these are being referred to in some cases as phase 4 clinical trials. And this is what we then call pharmacovigilance. So pharmacovigilance is very important once a vaccine is now being registered and it's available on the market. So just to give you an idea of what it looks like, very common and common side effects. So this is what we know from the clinical trials. And as you can see, visually, it's very few people. All these other very, very rare adverse events is things that we haven't seen in the clinical trials, and we can only pick them up once the vaccine is administered to thousands and thousands and millions of people in some of these cases. So just to make sure you all understand, an adverse event following immunization is anything that could happen following immunization. It could be a symptom, a sign, a laboratory finding, or a disease, but it's not necessarily linked to the vaccine or caused by the vaccine. And that's the reason why we need to do causality assessment, because we need to determine whether this event that we have seen was actually caused by the vaccine. And there were no other intervening factors involved in this whole process. So otherwise, people will say following immunization was caused by immunization. So we have a whole process in South Africa where adverse events are being reported. They are then investigated. Causality assessment is done to determine whether it's caused by the vaccine. Feedback is then given to the person who had this adverse event, serious adverse event. And all of this is done to make sure that people remain confident in vaccination. So, as I said, it's very important that we need to do causality assessment because we want to avoid people automatically saying the event happened after vaccination, therefore it happened because of vaccination. So this is just an example to show you post-marketing surveillance and a program that's being in place in Africa where the adverse events are being reported electronically and various countries' data is then combined. And this is what we've seen during COVID-19. So this program actually looked at more than 45,000 reported events and no additional safety signals were identified. So you can, I can also share this article afterwards. So just to look at the ingredients of vaccines, you know, asking whether they are safe or not. So what is in a vaccine? It is obviously the antigen, you know, that you want to protect the person, the disease you want to protect the person against. But then there's also excipients that's being used to keep the vaccine safe and make it long-lasting. And then there's also trace elements or residual amounts. So I'm just going to go over this briefly because I have more detailed information on this as well. But one of the adjuvants, it helps the vaccine to it stimulates so that you have a better immune response. The preservatives is to make sure that there's no contamination. And then the stabilizers is to help with the vaccine to keep it stable during storage and transportation. Then some of the residual amounts that will remain in the vaccine in very, very, very small quantities. Cell culture materials, which they use to grow some of the vaccines. Then you also find these inactivating ingredients. They use like formaldehyde to kill the virus or inactivate some of the toxins during the manufacturing. And then antibiotics, also in very, very small residual amounts that could remain afterwards, is to make sure that there's no contamination. Now, there are lots of questions around this, and specifically aluminum, where people then claim it can cause autism. And the answer is it cannot. It is very safe. And as I mentioned, you find it in very, very small amounts. And just to illustrate this, so a baby would be getting 3 milligrams from all the vaccines by the age of 1. But if you look at these amounts in baby milk formula and in breast milk, it is 38 milligrams and 7 milligrams. So just in the first 6 months of life, this is what a baby would get in naturally compared to 3 milligrams contained in the vaccines. The other one is then thimerosal. So that's being used as a preservative. Also, lots of misinformation being spread that it causes autism. It's very safe since the 1930s. It's very safe to use. And just to explain the difference. So thimerosal does not, which you find in a multi-dose vaccine, it doesn't contain the element mercury. It contains a compound of ethyl mercury, which is very different from methyl mercury, which you would find in fish, and it can be toxic and it can accumulate in the body. Ethyl mercury, which you would find in thimerosal in a vaccine, it is safe. It's got a very low toxicity. It doesn't accumulate in the body, and it is excreted within days. There's a lot of confusion around this. Then the last one.
Can we please wrap up?
Thank you.
Sorry.
I will do. So the last one is formaldehyde. And as you can see, you would find it in pears that we eat each and every day, and it's not even 1% of the in a vaccine what you would find in a pear that babies eat, we all eat. So just the last slide or two is on where can we find trustable information about adverse event. So the WHO VG Access, so you can follow the link there. And as you can see from this example, you can then read up on the events being reported globally around vaccination side effects or adverse effects. And then just a warning, so this is a website called the South African Adverse Event website, SAVERS in short. This is fake. It is, you can see they ask you to donate. It's run by an anti-vax group, and this is fake and misleading information. So it's something we need to guard against. So yes, this was very rushed, but thank you very much. And please, what are you doing as a journalist to prevent misinformation from spreading? Thank you very much. I'm happy to answer questions afterwards.
Great, thank you so much, Professor. As you can see, there's plenty of information out there about vaccine safety, and unfortunately, Professor Meyer has a wealth of information, and 15 minutes is not really enough time to provide all of that information. But if you have any concerns, I'm sure she will be willing to answer journalist questions about any specific concerns you may have. So the question is, how do journalists go about interrogating the information they receive about vaccines, including as new vaccines are being launched and when governments have specific campaigns around a specific vaccine? So next up is Dr. Sarah Downs, who will be giving us more information. As I said, some of this information is available on the first webinar in the series, so please do check that out on the link provided. Dr. Downs is a project manager epidemiologist at the Vaccines and Infectious Disease Analytics Research Unit at the University of Witwatersrand. She's a researcher. She leads research on impact communication engagement with child health and mortality prevention and surveillance. She collects, analyzes, and shares evidence to prevent child mortality, adverse pregnancy outcomes, and other causes of death within adults. With experience and expertise in infectious disease surveillance, vaccines, and vaccine trials, her research focuses on epidemiology, maternal and child health, and science communication. Sarah was selected as one of 35 top performing graduates globally for the Gates Notes deep dives on pandemic prevention, and served on a reference group for a novel water-based COVID-19 surveillance project for non-SWIFT communities. She has contributed to vaccine literacy, public health messaging, and pandemic response through the school and NGO presentations, webinars, and social media. Her science communication work has been featured on BBC, CNN, Time, and Global Citizen Africa. Without further ado, Sarah, can you please go ahead with your talk?
Hi everyone, I'm very excited to be able to talk to specifically journalists today, and I'm very sorry that I don't have a presentation to show. I had a bit of an IT mishap this week. So just to reiterate what my colleagues before me have said, vaccines are the most effective and the safest public health tool that we actually have available. They've saved 150 million lives over 50 years, and this information is from the WHO. But yet, misinformation is increasing. And a lot of the reason for this is because vaccine opponents and spreaders of misinformation have gained a much bigger platform, as Dr. Harris spoke about. And unfortunately now, they are actually being put onto health advisories in the USA. And so it's so important for journalists to be involved in not only countering misinformation, but also preempting misinformation. And I think one of the things that makes it very difficult for journalists as well as for parents who are concerned is that often science in articles or articles that look like valid scientific resources are also used to spread misinformation, often by misquoting or by drawing conclusions from them that the studies don't have the power to draw. And so because of this, I think one of the key things that journalists and science communicators can do is actually get involved in knowing how the science is actually generated. So one of the important things is knowing about different study designs, which different study designs can answer different questions, and especially around vaccines. So we have what's called the pyramid of evidence. And at the top of the pyramid, the most important resource are systematic reviews and meta-analysis. So this is where the authors have gone and systematically gone through a search of the literature, put together all the evidence, and actually done an analysis of what all these articles, then what the conclusion is. So that is the best available evidence you have. The next best evidence is randomized control trials. So these are trials where basically they've done their best to eliminate all sorts of biases, made sure both groups are equal and that they're blinded, etc. And there's a lot of rules in place, which Dr. Mayer obviously went through. And then underneath that, you have non-randomized clinical trials. And underneath that are observational studies that have a comparison group, and then case series and reports. And then at the bottom of the pyramid, so just to reiterate, this means it's the lowest form of evidence, is expert opinion. And so it's very important to make sure when we are reporting on vaccines that we're starting from the top of the pyramid. If there's a systematic review and meta-analysis available, using that as the evidence and not a single study. If there's a randomized control trial, that is the second most important evidence. And at the bottom is expert opinion. And so I think also in terms of study designs, the Journal of the American Medical Association has a really good series that explains what's a case control study, what's a randomized control study, what's a cohort study, etc., and what they can actually be used for. So I'd really advise that people go and brush up on that. The second thing that you can do to really make yourself in a much better position to report on vaccines is by going and doing a GCP course. This is called Good Clinical Practice. And basically, this course is done by anyone who works on vaccine trials and anyone who is involved in the trial process and the authorization of vaccines. And you can do some online courses through, for example, Coursera, or the Mayo Clinic has a really good short online course. And once you know the process of actually how vaccines get from the development stage to the approval stage and roll out to the general public, it obviously makes it a lot easier to counter the misinformation and to know which studies are actually valid. Another key thing is that a lot of science that has been done recently, and mainly during the COVID pandemic, has shown that preventing vaccine misinformation before it actually takes hold, so almost vaccinating against misinformation, is extremely important. And here the media can really play a key role. And the reason that this is once someone believes something about a vaccine, it's actually more difficult to change their mind, no matter how many facts you present to them. And an example of where the media could have been more effective at assisting is in 2023, there was a small measles outbreak here in South Africa. And what happened was some of the bigger influencers within South Africa in the misinformation space actually spread misinformation, saying that the Catch-Up Measles campaign, where they were going around to schools to vaccinate children against measles, that they were actually using it as an opportunity to give the COVID vaccine. And this was obviously misinformation. But what could have been done differently is that if there had been extensive reporting on the fact that we had a small measles outbreak, and that it's very usual for the government then to go around schools and vaccinate, and that this isn't abnormal and that this happens periodically, as well as more effective campaigns on measles vaccines, etc., information for the public being spread by journalists could have really helped. And then the other obvious example, which Prof. Mayer obviously spoke about, was COVID vaccines. When they came out, people thought that they were developed too quickly, and a lot of reporting and information about how the pipeline of these vaccines, how they were able to be developed faster, as Prof. Mayer had gone through, it would have been really, really helpful in that situation. And one of the things that we have upcoming is that there's a couple of new maternal vaccines that will be coming out. And it will be really important for journalists to cover these stories of these vaccines as they're being developed, how they work, and that they're safe, etc., before they're actually released, so that we can really preempt this vaccine misinformation before it takes hold. We also need to address concerns as they come out, kind of have an ear to the ground. And I think it's really important for every health journalist to have a trusted network of scientists. So these are people that you've validated, that you know they have the right connections, as well the right credentials, as well as connections within the health department, etc., so that you know what vaccine campaigns are coming up, you know who to contact, so that you can very quickly develop a story that is from a trusted person. So I think in terms of some of the myths around vaccines, it's also important for journalists to know who the misinformers are, who it's spread by, and why their credentials in specific fields are important. So as an example, in South Africa, we have a wellness doctor called Dr. Kathrada, and she usually does weight loss and aesthetic surgeries and things like that. And she moved into the misinformation space during COVID, and her aim was to actually sell detox protocols, so to make money off those detox protocols. And basically, her credentials are as a wellness doctor. She has no experience in vaccines, in infectious diseases, or even as a GP, really. And so it's so important for us to go back, look at what people's credentials are, see what they have published before. So anyone who is talking on vaccines to a journalist should have some kind of publication background. Is it specific to vaccines? Are they, for example, a molecular biologist that's worked on plant biology, for example, in which case they're not really qualified to talk about vaccines, compared with a molecular biologist who's worked specifically on infectious diseases and on vaccine trials. And then we also get subject matter experts. So for example, a person who's an immunologist might have studied different areas of immunology, and they would be really well equipped to talk about vaccines, whereas a scientist who is in another field is not as well equipped. So a scientist is not a scientist. We need to actually make sure people are subject matter experts, and wherever possible, actually delve into the specific vaccine. So for example, Prof. Groom has done a lot of work on rotavirus vaccine. And so if you wanted to talk about the rotavirus vaccine, she would be an excellent person to contact. And you can look into her history and you can see she's got a great publication record on the subject. And then looking at, for example, a cardiologist is not an expert in vaccines. So just to delve into some of the myths that have been circulating in the past around vaccines, and I know some of the other presenters have covered some of these, so I'll go through them quite quickly. So the first obvious one is that vaccines can cause autism. So the way that you would counter this misinformation is that there have been multiple large-scale studies that have been done with millions of children that show no link between vaccines and autism. And of particular interest here, and Prof. Mayer actually showed this article on one of her slides, is there was a large meta-analysis done by an author called Taylor and his colleagues, and it was in 2014 in the journal Vaccine, and it was a meta-analysis of all the studies that had been done prior to that on autism and vaccines, and they showed that there was absolutely no relationship between vaccines and autism. The other common myth is that natural immunity is best. And here we can kind of look at, there's a lot of vaccine information out there where they show the side effects of vaccines, and they also show what the disease can cause. So natural infection can, of course, lead to immunity, but this is not always very broad. So if we take the PCV vaccine, for example, it covers 13 serotypes of a bacteria called the pneumococcus, of which there are 100 different serotypes. So you would have had to be exposed to each one of those 13 serotypes that are invasive and can cause severe disease in order to form the same level of immunity that you would get from just one vaccine. And obviously, going the natural route and being exposed to a disease comes with a lot of risk of illness, complications, and death, whereas vaccines give you this immunity without any of that risk. And the next thing is that vaccines contain harmful ingredients. So Prof. May again went through a lot of these things already. And I'm just going to go through one of them that she did go through and break it down how you would actually counter this. So for example, the aluminium that's in vaccine, it's not elemental, it's actually aluminium salt. And we can kind of think of this in the same way that we think of sodium chloride, which is table salt. So sodium on its own and chloride on its own may be harmful, but it's sodium chloride as a salt, and it's perfectly safe for us to put on our food. And then another thing is that a lot of parents say, our kids are getting too many vaccines, and can their immune systems cope? So just to put this into perspective, the way that vaccines have been developed, they've actually become a lot more streamlined, and the production is more streamlined. We've got a lot better technology. So in the mid-80s, a child under 2 years old received vaccines against 7 diseases, and these involve 3,000 antigens. So the antigens is the thing that your body responds to from the disease. Now we have vaccines commonly available for 15 different diseases, and there's only 180 antigens. And so you're really not overwhelming your child's immune system. We are exposed to so many different germs every single day. Another common myth is that vaccines are only for children, therefore adults and pregnant women shouldn't get them. Whereas we know that adults should get the flu vaccine, the COVID vaccine, the shingles vaccine, and there's maternal vaccines that are available. For example, the pertussis vaccine, the tetanus vaccine, and newly coming out, which I think that journalists really need to be on top of, is the new RSV and GBS vaccines. So these will be offered to pregnant women to prevent either stillbirths or to prevent disease in the infants when they're born and they're still really vulnerable and not able to be vaccinated themselves. Another common myth, which Prof. Groom had touched on, is that vaccine preventable diseases are seen as rare. And this is because of vaccines. They can come back rapidly and spread through unvaccinated communities really fast. And an example of this is the outbreak of measles in Texas recently that spread through unvaccinated communities.
Sorry, Sarah, can we wrap up?
Yeah, sure. So I think some of the things that you can go through are, apologies. I think some of the other myths that have come out are that vaccinated children are maybe a little bit more unhealthy than unvaccinated children. And this is something that unvaccinated parents tell their peers all the time. And this is not true. And there's a paper by an author called Glantz from 2018 published on USA hospital data that showed that non-vaccine preventable diseases in children from 2 years old to 4.5 years old, there was no difference in visits to the emergency room and visits to the hospital for children that were vaccinated versus those that weren't. And so just to really reiterate, it's so important for journalists to not only cover stories about misinformation and debunk that misinformation and put the right information out there, but when there's new vaccine campaigns or new products coming out, to actually put out information about these vaccines to help build public trust. And I'll end there.
Thank you, Sarah, for highlighting all of that information, especially how to check vaccine information, looking at the weight of the evidence, understanding the type of research undertaken, and especially the importance of meta-analyses. And thank you to all the presenters for enlightening us about vaccines and the false information about vaccines. I'm now going to open up the floor to questions. I see there are many questions in the chat box. I don't know if we want to go through these. If we can, sorry, just hold on. I keep seeing this AI system taking notes. So in terms of articles, if you want to follow up with any of the researchers, please just email me and I will link you to them so that they can provide any articles on any topic that you want to know more about. So in terms of the sort of quality of academic sources being shared, Mallory, I don't know if you, Dr. Harris, I don't know if you have anything further that you want to say on that, whether good quality academic information is being shared and if it's being used in ways that spread misinformation or not. Do you have any comment on that? Mallory? Not sure if Mallory's still in the group. Does anybody else have anything to say on that question?
The microphone is working.
Okay. Apparently, Mallory's having difficulty with her microphone. Okay, so I also want to, yeah, is there any other questions that people want to ask at the moment? One of the questions was, vaccinated people think they are 100% safe. Is this correct? And I see that Dr. Groen, Professor Groen provided an answer to that. Does Professor, do you want to just highlight that point?
Yeah, sure. Thanks. Yeah, I think it's. I mean, there are vaccines that are very effective. You know, something like yellow fever, and you know, where you only need one vaccine and you're protected. But the vaccine kind of efficacy does range from vaccine to vaccine, and so some vaccines are kind of highly effective, some not so much. And so I think yeah, it really depends on the vaccine, and I guess really important how you frame it in terms of, especially from the media perspective. In terms, but you know, for example, like a malaria vaccine is only around 50% effective, but there's such a high burden of disease that even a vaccine that's 50% effective has a tremendous impact on mortality and severe disease. And also just to, you know, the other point that I mentioned was, you know, some people think they'll get the flu vaccine and then they say, oh, but you know, I had the flu vaccine and then I got flu. And I think it's the perception that vaccines are very specific against a certain virus or bacteria. And so you may be protected against influenza, but then you may get rhinovirus or some other respiratory virus and have symptoms, and then people automatically think the vaccine is causing the symptoms, or have the vaccine and then, you know, are infected with something else and then believe the vaccine's got adverse events. So I think just important, I guess, yeah, to always be educating the public around, you know, what do we mean when we say, you know, protection by vaccines? And I think vaccines are really good at protecting against severe disease. So you may still get the illness, but it's much less likely that you're going to die from it. So I think it's those kind of nuances just around it. It's not as easy as, yeah, I have the vaccine, I'm always protected, but always the message protected against severe disease.
Great, thank you. I see another question here is whether or not the Child Health Act is going to be protecting children against vaccine hesitant parents. I presume they mean that the government is going to force parents to vaccinate their children. Does anyone have any insight on this?
Maybe I can give a comment on this. So, you know, when it comes to mandatory vaccination, it's actually very difficult, especially in South Africa, because we have a very strong constitution. We also need to make sure that, you know, say, for instance, you want to implement mandatory vaccination. do all children and parents have access to vaccines? So we still battle with some issues of access as well. And then the other issue that we need to think about is what effect will it have on the population if you implement something like mandatory vaccination? We always say a better approach is rather to change people's perceptions. So we want to, we want people to actually demand vaccines rather than, to say vaccines are not safe and so on. And I mean, we're speaking a lot about media and information that's being spread. And as I've shown, it's actually very few people who are so strongly out there in spreading the misinformation. So everybody, us, I mean, all organizations, everybody should actually be going out there and spread the correct information so that the misinformation can just drown. Yeah, that's my opinion. Thanks.
Great, thank you very much. And then one of the questions was about whether the accelerated process of approving the COVID vaccine meant that there were more negative side effects from that vaccine compared to other vaccines. Does anyone have any insight on this?
Maybe I can also answer that one. So we need to remember that these vaccines, as I explained, so we know about the minor and, the more common side effects, which are minor and they subside within a few days. So, but because the vaccine hasn't been on the market for such a long period of time, and when it was now administered to so many people, millions, billions of people, that's when they were able to pick up those very, very, very rare adverse events that you would find 1 in a million or 5 in a million. So compared to another vaccine, that was much more visible. So, but in general, I mean, the vaccines were really found to be very safe. If you look at all the papers and all the reviews that's been published. So according to me, no.
Okay, great. Thank you very much. Is there any further questions from the audience? We are actually 1 minute over time, so I don't want to keep our speakers further. But if there is any pressing questions, please let me know. But also, as I said, please contact me if you want to speak to any of the presenters. And I just want to also highlight that the next event in this webinar series will be taking place on the 5th of September 2025. I'm now going to post the link in the chat box for signing up for that event. That will be on sexuality and sex-related information, about which there is quite a lot of misinformation in the public domain, and especially looking at also included in that is looking at the sexual health of teenagers. Yes, please do join us on September the 5th for that final webinar in the series. Thank you again to all the presenters. You've done a fantastic job of giving us a summary. I know that there's a lot of information that actually that journalists need to grasp. So giving you 15 minutes is really a tough challenge. So we really appreciate the efficiency with which you've delivered the information. Thank you so much. Great. Have a good day further. Bye-bye.